Dear colleagues, dear friends, it's a pleasure to share with you my experience, and I would like to explain the interest to use contrast enhanced for the evaluation of treatments. So, why do we need tumor functional evaluation? Because new treatments in oncology induce a destruction of vascularization. And as you can see on the CT scan, so before treatments and after 9 months, according to the RECIST evaluation, we have a stable disease, but everybody understands in this room that probably we have a destruction of the vascularization. And the goal of the functional imaging is to try to quantify this destruction and to link this modification to the outcome of the patient and to the overall survival. And the FDA asked us to demonstrate this level of validation for the biomarker. So currently we have no consensus for the biomarker, and this is the same problem with DCE-US, CT perfusion, and DCE-MRI. So we are able to calculate the blood flow, the blood volume, and the mid-transit time, and currently no consensus. So with the DCE-US, we standardize, and currently we have the best temporal resolution. With the CT perfusion, we perform 1 acquisition per second. With DCE-MRI, 1 acquisition every 2 seconds. But with the DCE-US, we are able to record 4 frames per second during 3 minutes, and we record the washing and the washout automatically. So if you want to evaluate the blood volume, you calculate during the washing and the washout the area under the curve, or during the washing or the washout, and the time and the peak intensity. All are correlated to the blood volume. If the oncologist asks you to evaluate the blood flow, which perfors the tumor, you need to calculate the time to peak or the slope during the washing. And after, you could also calculate the mean transit time. So this methodology was published with European colleagues, Italian and German and UK with Edilin, and we have a consensus in Europe. We inject the Sonovio during the bolus injection. We perform the quantification from the raw linear data or using adapted software. And we propose to record during 3 minutes the raw linear data. And if you evaluate the HEC, this is 5 minutes. So in order to validate the biomarker, we start with 5 monocentric studies in my institution in order to understand which is the best parameters. So we evaluate in HEC with avastin, renal cell carcinoma with sunitinib, GIST with mazatinib, phase 1 with sorafenib, and HEC with sunitinib and Nexava. We perform more than 800 DCE-US, and we understand among the 7 parameters, only one is always linked to the response. This is the total integration during the 3 minutes. This is the area under the curve. So after, in order to perform the validation according to the Oxford guidelines, we move to the multicentric study. And we have a huge grant with the Ministry of Health in order to extend this methodology using the raw linear data to demonstrate the feasibility in 19 centers, and 65 radiologists participate in order to determine which is the best parameters, probably the eye under the curve, but also which is the best timing, which is the cutoff. Remember, for the RECIST evaluation, this is a decrease of 30%, and also the timing and the cost. We standardize, so the settings were fixed. We select one target, we inject the total vial, we record 3 minutes of raw data, and we send the data to the huge database, and we calculate the 7 parameters. We include more than 500 patients. We perform more than 2,000 DCE-US, 1,700 CT scans with a RECIST evaluation, and we include a lot of renal cell carcinoma and HEC, but also more than 50 colon cancer, breast, melanoma, and GIST. And all patients were treated with the main treatments, anti-angiogenic treatments, so sorafenib, bevacizumab, and sunitinib. Concerning the validation of biomarkers, we confirmed the area under the curve with a significant value, and the timing is at 1 month. And using the ROC curve, we determine the cutoff, and the cutoff is a decrease of 40% of the area under the curve at 1 month. And with this cutoff, we are able to demonstrate a correlation with a progression-free survival, and for the first time, a correlation with the overall survival. Remember, this is the best endpoint for the FDA, and this is the first study comparing CT perfusion and DCE MRI, able to demonstrate this level of validation. So this is an example of the patient, so with a liver metastasis before treatment, so this is a vascularized lesion, and after 1 month, we have a strong decrease of the vascularization, and with the quantification, we have a decrease of 56% of the area under the curve at 1 month. So this methodology was published for the standardization in investigative radiology in 2012, and for the validation of the cutoff and the biomarker in 2014. We implement this indication in European guidelines in 2011, and we have a new update in 2017 in January. So we have the level according to the Oxford recommendation, the level A1B, and if we want the maximal level, we need to perform 2 multicentric studies, and currently in France, we perform the second study in colon cancer treated with VEGF trap. We also implement this indication in international guidelines with American colleagues and Asian colleagues also. And the good news, the last month we published in Nature Review Clinical Oncology with 17 experts focus on biomarker, and for the first time the eye under the curve with DCE-US at 1 month was implemented as a biomarker, as a PET or MR or CT. So for the future, we need to improve the process, and we have 2 ways. Firstly, the tracking. In the STIC study, the tracking took 12 minutes for the manual tracking, and also we want to increase the sensitivity because we determine the quality score, and we are not able to quantify 3% of the DCE-US. So we would like to decrease this number. So concerning the tracking, this is a good news. In the new Applio High series, we have now the motion tracking. So this is automatic tracking. So it takes few seconds to perform this tracking, and this is a machine will perform this tracking. And we also implement the time intensity curve from my institution, and so now you are able to calculate automatically in few seconds the 7 parameters. So the next step also is to increase the sensitivity, and in order to have a very good homogeneity in the superficial and deep lesion. And you could check that on the right, we have a very nice B mode now in order to see at the beginning the target that we need to follow during the 3 minutes of acquisition. And to finish, the next step, with the same probe, we are able to have a very good sensitivity and homogeneity. So this is a patient. You could see that probably we are about 13 centimeters, and we are able to see the very small lesion in the superficial area, but also in the deep area in the segment 7. And if with the same probe, we are also able to visualize, I think the video, check, okay, to see the vascularization in the superficial lesion. So to conclude, I hope to convince, and now we standardize the DCE-US in the multicentric study. So you need to use the raw linear data and the bolus injection. And with this methodology, you are able to evaluate the blood flow, the blood volume, and the mean transit time. And with this methodology, we select one biomarker. This is the area under the curve, correlate to the blood volume at 1 month, and with a decrease of 40%. And now you are able to support this with a publication in Investigative Radiology and Nature Review Clinical Oncology. Thank you very much for your attention.